So good morning and good afternoon, everyone. My name is Tamil Kendall, and I'm the director of the Partnership for Women's Health Research Canada, which is also known as POWER. POWER brings together the Women's Health Research Institute in British Columbia, the Women and Children's Health Research Institute in Alberta, the Women's College Research and Innovation Institute at Women's College Hospital in Ontario, and IWK Health in the Maritimes together in our vision of better health for all women, trans, and non-binary people through research equity, excellence, and inclusion. And so it's very exciting to be here today with all of you to have a conversation about research and practice excellence through inclusion in the area of women's heart health. And we have a fantastic, really stellar pan-Canadian panel of experts, community advocates, and researchers to talk about this with us today. So just before we move into the presentations and the panel, I'd like to acknowledge that I live, work, and play on the traditional territories and on the territories of the Lekwungen peoples, the Esquimalt and the Songhees Nation. And since we're joining from across Turtle Island today, I'd like to invite you to take a moment to think about and express gratitude for the traditional peoples and the traditional territories of the nations whose land you are living on. So February is Heart Health Month, as I'm sure you are aware, and I'm really honored to have this lineup of researchers and advocates with us today. The format is a seminar format, so we'll hear each of the panelists speak, and I encourage you in this time to put your questions into the chat, and I will circle back to them at the end when we have a panel discussion and the opportunity to hear from all of our panelists. So without any further ado, I'm delighted to invite Lisa Comer, who is going to speak about the Canadian Women's Heart Health Alliance, advocating for sex and gender equity in women's cardiovascular health. I'm sure that many of you know Lisa. She has a degree in psychology from the University of Western Ontario, a diploma in business administration from Algonquin College, and has also completed a professional certification in knowledge translation through the Hospital for Sick Children in Toronto. She has over 15 years experience in the area of learning and development, both in high-tech and in healthcare settings. And she's been with the University of Ottawa Heart Institute since 2009. Currently, she's the Knowledge Translation Manager for the Canadian Women's Heart Health Centre and manager of the Canadian Women's Heart Health Alliance. This dynamic role allows Lisa to oversee a variety of local and national projects aimed to educate, inform, and address the gaps in cardiovascular care, research, and support for women in Canada. Welcome, Lisa.
Thank you, Tamil. I appreciate it. And thank you, everybody, for the opportunity to speak to you today. Anytime I can speak about the Alliance, I'm happy to do so. So again, thank you. So today I'm going to be speaking about the Canadian Women's Heart Health Alliance and how we are advocating for sex and gender equity in this space of women's cardiovascular health. So let's talk about the issues to start here. Cardiovascular disease is the leading cause of death for women worldwide. And unfortunately, you can see from the graph, Canada and the United States have been reporting an increase in deaths for women from heart disease. And our goal is to change that. Heart disease is the leading cause of death worldwide for women, and yet many are unaware of this risk. Every 20 minutes, a woman in Canada dies from heart attack or heart disease, and it claims 5 times more lives than breast cancer. So despite this, Heart disease is often overlooked as a women's health issue, and the rates are increasing, unfortunately, particularly among women of the ages of 35 to 55. And this is due to lifestyle factors and other risks. One of the biggest challenges is that many women see heart disease as a one-time event rather than a lifelong condition, and that leading them to return to potentially old habits instead of managing their heart health proactively. So awareness and action are critical in reducing this impact on heart disease and women. In 2018, Heart and Stroke released the Misunderstood report, exposing this critical issue, that women's heart health has been overlooked for, as we all know, way too long. And despite making up over half the population, women have been underrepresented in heart disease research. 2/3 of clinical studies have been focused on men, and as a result, most diagnostic and treatment guidelines are based on data from middle-aged white men and not women. This gap has real consequences, and women experience heart disease differently, yet their symptoms are often missed or dismissed. Early heart attack signs go under-recognized in over 50% of women, and those without classic heart chest pain are even at greater risk of misdiagnosis. Many delay seeking help due to fear, not wanting to be a burden, yet in a heart attack situation, every minute counts. So why is this happening? We talk about different symptoms. Women having heart attacks often experience symptoms such as nausea, fatigue, dizziness, indigestion, and back and shoulder pain, and those symptoms are frequently misinterpreted or overlooked. Lack of awareness, which is what we're talking about today, is that many women don't realize that heart disease is their #1 health threat. And then healthcare knowledge gaps. Many providers still rely on outdated male-focused research. So the result is women are understudied, underdiagnosed, undertreated, and that leads to worse outcomes. A national survey found, this is from a few years ago, that 60% of high-risk women underestimate their heart disease risk, and that highlights a very dangerous disconnect. But I'm happy to say that progress is happening. The Canadian Women's Heart Health Alliance is a network of volunteers, of experts and advocates dedicated to improving women's cardiovascular health across the lifespan. Our mission is to collaborate on implementing the evidence, transforming clinical practices, and influencing public policy to close this gap in inequities in care. This week, just wanted to highlight, hot off the press, that we have reached an exciting milestone. 250 members have joined or are part of the Canadian Women's Heart Health Alliance, representing all 10 provinces. And our diverse membership strengthens, I know it's so exciting. It strengthens our impact, and it brings together healthcare professionals, researchers, policymakers, trainees, and patient advocates. And as you can see from this pie chart, 20% of our members, almost 20%, are individuals with lived and living experience. And their voices are essential in ensuring that our initiatives are patient-centered and truly reflective of the needs of the women across Canada. All of our projects and initiatives fall within one of the 5 pillars or themes. Each theme is represented by on our executive steering committee by both a patient advocate co-chair and a healthcare professional co-chair, ensuring that a balanced and inclusive approach to decision making. We also have 2 trainee representatives because we recognize the importance of supporting the next generation of women cardiovascular health researchers and clinicians. Investing in future leaders, I think we all know this, but just going to mention, investing in future leaders is critical to sustain progress in this field. So with more people, we can expand our impact and advance education, research, advocacy, and those system level changes to drive meaningful improvements to women's cardiovascular health. So here are some of the amazing initiatives that we are currently working on within the Canadian Women's Heart Health Alliance. You can see a number of us, you will today, that we're all wearing red in support of tomorrow's Wear Red Canada Day. And that's on February 13th every year, and it's to raise awareness about women's heart health. Beyond wearing red on February 13th, here's how you can get involved. And that's all about sharing our key messages, attending an awareness event or hosting an awareness event, posting on social media, making sure you're using those hashtags, Her Heart Matters and hashtag Wear Red Canada. and more. So you can access the wearwigcanada.ca website for all the information, all the events that are happening across Canada, and we really hope that you can join us, because together we can drive the awareness and action in this space. To reach more women across Canada, especially those with higher risk of heart disease, the Alliance has developed multilingual resources, and these cover topics such as heart attack symptoms for women, causes of risk factors, and ways to reduce our heart disease risk. This is a huge undertaking, multi-phase approach. This is the first of all of it, where we are translating those key messages into 17 different languages. But the goal is to develop relations with various cultural communities to really help target and, well, actually adapt our resources and tools and PowerPoint presentations, et cetera, to reach individuals where we possibly can. So this is an initiative that we're very, very excited about, and please feel free to have a look on our website to see all of the translations and languages. So training and education. We know there's significant gaps in the awareness and knowledge when it comes to heart disease in women, both among healthcare professionals and among women themselves. Many clinicians in Canada are not fully informed about the incidence, prevalence, significance, and management of heart disease in women. And at the same time, many women underestimate their own risk for serious illness or death for heart disease. So with this significant gap in awareness and knowledge, we know that there was some work that needed to be done in this space. So the Canadian Heart Alliance is leading education and training initiatives to embed sex and gender specific content into our cardiovascular learning. Few examples is that we have a 3-year pilot program for cardiology residents. It's accredited e-course, it's bilingual, toolkit has real life case studies. And we also reach out to high school students, younger audiences, with lesson plans and videos. In 2024, we held over 90 presentations in Canada, educating over 3,700 learners. So lots is being done in this space. We also have an accredited conference that's happening in April. It happens every 2 years, and this is a really amazing opportunity for healthcare professionals to attend and to learn the latest information about women's cardiovascular health. As you can see from this slide, there are several initiatives underway to improve cardiovascular care for women here within the Canadian Men's Heart Health Alliance. We are actively working to reduce those barriers, including launching a new chest pain protocol for the emergency department with plans for a multi-site pilot project. We also will be sharing the results from a national survey on the current state of cardiovascular care for women in Canada. And recently, we published the first of many clinical practice updates focusing on MINOCA. And also, we launched a community of practice recently with all 7 women's heart programs across Canada to develop an operational manual for institutions interested in starting their own programs. Here's just a highlight. I know we're going to be talking about this later in future talks, but we had a atlas, which is an amazing live document highlighting the key areas in sex and gender-based considerations and research. And this is chapter 9, which was our final chapter, highlighting 4 areas that we need to work towards. And this is what we're doing in terms of our future directions, is we're talking about clinical practice changes, research, advocacy, training, and education. And lastly, we can't do this on our own. This is a huge undertaking, and we're proud, so proud of what we've accomplished so far as a team. But to continue that momentum, we know the more volunteers we have, the more we can do. So if you are interested and available, we'd love to have you join the Alliance. Please have a look at our website for more information. Thank you.
Thank you so much, Lisa, for that inspiring introduction to the really well-rounded work that the Canadian Women's Heart Health Alliance is doing. I was taking notes, very interested to see what happens with the chest pain protocol and the community of practice. Really exciting. So now we're going to turn to a presentation from Dr. Tara Sedlak and Emily Therberg, Women's Heart Health, Sex Differences and a Decade of Research. So Dr. Tara Sedlak received her Doctor of Medicine, Internal Medicine residency and cardiology residency from the University of British Columbia. She also completed a fellowship at Cedars-Sinai Medical Center in Los Angeles, focused on women's heart health, particularly on chest pain syndromes in women with no significant coronary artery disease. Dr. Sedlak practices general cardiology at Vancouver General Hospital and BC Women's Hospital and is the director of the Leslie Diamond Women's Heart Health Clinic. Her research interests include etiologies of myocardial infarction and chest pain in women with non-obstructive coronary artery disease and therapeutic strategies in microvascular coronary dysfunction and coronary vasospasm. She is joined by Emily Therberg, who is a researcher and aspiring clinician scientist. Emily is currently a PhD student in medical genetics at the University of British Columbia, supervised by geneticist Dr. Anna Lehman. She has been a research coordinator and analyst for the Leslie Diamond Women's Heart Health Clinic Research Registry since 2021, supervised by Dr. Sedlak. Her research interests, unsurprisingly, lie at the intersection of clinical genetics, sex and gender differences, and heart disease, specifically microvascular dysfunction, coronary vasospasm, and monogenic causes of premature heart disease. Welcome, Tara and Emily. Please go ahead.
Great, thank you. I'm hearing my video is off, but I can see myself. Tamil, can you see me?
I see you, Tara.
Good.
You look
Okay,
great.
awesome. Great. Thank you so much. Okay. Yeah, so Emily and I are going to speak about our research on women and heart disease, but I'm going to do a lead up and then Emily will get into our actual research findings. Next slide. So what we wanted to talk about today, I wanted to bring up two different women with lived experience, just two stories that really got me into this field. I want to talk a little bit about the scope of the problem, although Lisa Comer did an excellent job of highlighting that. Some sex and gender differences between men and women with respect to heart health, outcomes in our own Women's Heart Health Center, and then a few highlights at the end: investing in women's heart health research, why is it important, and then how to protect our heart and next steps. So I always like to start with a couple of stories because it really brings it home for people and for myself. Lila, obviously that's not her real name, but I met her over 20 years ago. I was actually a student at the time. I was a resident at the time. I was training in cardiology and I was thinking about what I wanted to do in cardiology. And she was a 45-year-old woman who went through premature menopause before the age of 40. And her mother had had a heart attack at the age of 54. And she did have a history of mild anxiety. It was well managed and well treated, and she saw her practitioners regularly. And she was at home alone one evening when she started to experience pretty severe chest tightness. And at first she thought, oh, geez, maybe this is a bit of heartburn. I'm going to take an antacid. Didn't help. Maybe this is my anxiety, but really nothing in terms of that sort of was flashing lights for her. And so she thought, geez, this really, like, I'm looking up the signs and symptoms of heart attack. This is pretty severe chest tightness. It's getting worse. I'm sweating. I'm short of breath. I'm going to call the EMS. And she called 911 and EMS came and saw her. And they took a history and basically said to her, we think you're having an anxiety attack, a panic attack. And they made the decision at the time not to take her into the emerge. And so she stuck it out at home on her own by herself. And 6 hours later, she was still having severe chest pain, felt that she was going to faint, really short of breath, starting to go down the arms, up into the jaw. And thankfully, she had the wherewithal to call again and called the ambulance again. And the second time they came and took her into emerge, and lo and behold, she was having a massive heart attack from 100% blockage in one of the arteries surrounding her heart. And now she was 6 hours into her heart attack. And of course, time is muscle. So I always go back to that. She was one of my very first patients that was just so meaningful to me. And we can sort of talk about where we've come from there. Next slide. So Corey is a more recent patient who I met, I would say in the last 10 years, 5 to 10 years. And she's a 52-year-old female. She had a hysterectomy and oophorectomy for severe menorrhagia and endometriosis. So they took out her uterus, took out her ovaries, and she promptly went into menopause. 3 weeks later, she started to experience pretty new exertional chest pain. So every time she would walk or do something, she had pretty significant chest pain. GP was worried enough, sent her for an urgent stress test. That stress test was very abnormal. And in fact, the cardiologist who was supervising the stress test didn't even wait to see her another day, saw her that day and said, you know, you've got to have a blockage in the arteries as a cause for your symptoms. Let's send you for an urgent angiogram, which is where we put dye up into the arteries surrounding the heart and look for blockages. And lo and behold, angiogram was completely normal. And she was told that nothing was wrong. Unfortunately, that didn't end the story for her. She continued to have ongoing chest pain. She visited her family doctor at least 5 more times in the coming months. She went into emerge twice more because she really felt like this was heart related. And eventually her GP, who is excellent, said to her, you know, I gotta say, I realize your angiogram's normal. This sounds heart related. I think something's been missed, and referred her on to us. And lo and behold, it ended up turning out that it wasn't her large blood vessels giving her the problem. It was actually the small blood vessels. And we'll go into that in more detail in the coming slides. Next slide. So scope of the problem, I don't want to spend a lot of time on this because Lisa Comer already did an excellent job, but just highlighting that, you know, in Canada, cardiovascular disease is a leading cause of death and probably the primary cause of premature death amongst women in Canada. Women 5 to 6 times more likely to die of heart disease compared to breast cancer. I tell my friends that, and all of them are just stunned. They had no idea about that. 60% of heart disease presents as a heart attack. Just like our first woman, the 45-year-old woman, no warning. Women are less likely than men to seek medical attention. And when they do, they're less likely to receive a diagnosis for their heart condition. And a lot of that is because of, in the past, we used to just study men. We used to use techniques that were studied in men, and we would miss things such as small blood vessel disease with angiograms, which are considered to be the gold standard test. Next slide. Even more worrisome is that only 37% of young women believe that their heart disease can be different for women compared to men. Only 28% know that heart disease and stroke are the leading cause of women's death worldwide. And this one really troubles me. Only 1 in 5 women's doctors talk to them regularly about their heart health. So we're going to come back to this at the end. But at the end of the day, when people ask me what's the #1 thing I can do, I say, book an appointment specifically with your family doctor to talk about heart health. Don't talk about anything else. That is the appointment because it's just not being done. Only 1 in 5. Next slide. So what are the causes of heart disease or heart attack in women? Still traditionally, a blockage in the artery caused by plaque and calcium, or a buildup of plaque and calcium, the so-called widowmaker or jammer inside the artery, is the most common cause of a heart attack. But in 10% of women and only 3% of men, a heart attack is not caused by any blockages at all. In fact, you can do this angiogram, put dye in, completely clear, it looks like you're 20 again. And we know that, and that's called MINOCA, which is an MI, myocardial infarction or a heart attack, without any significant coronary artery disease or blockages. And that's 3 times more common in women than men. And INOCA, which is the stable counterpart, so no heart attack, but having ongoing chest pain, just like our second woman, Corey, exertional chest pain, hasn't had a heart attack, but sounds cardiac, keeps presenting to emerge with heart pain. Lack of blood supply to the heart, but no blockages in the large blood vessels. Again, much more common in women compared to men. Next slide. So what are some of the causes that we have determined over time as a cause for these MINOCA and INOCA events? Well, certainly we've done a lot of research into this, and Emily's going to speak about this. But still, you can have a heart attack from plaque inside the artery. But because we're so good at treating heart attacks up front with blood thinners, we often treat with 3 or 4 blood thinners, and lots of medication, that by the time you get an angiogram done, which is sometimes a few days later if you're coming from up north or rural areas, that blockage may have resolved by the time you get the angiogram done. But if you actually put a special camera down the artery, something that we've helped develop and really do a lot of now here in Vancouver, if you put a camera down the artery, you can actually see the residual bits of the plaque that was there. And yet when you put just the dye in, it doesn't look that impressive, and it's kind of called as normal. So that's in red, there are atherosclerotic causes. There are non-atherosclerotic causes, so spontaneous coronary artery dissection, that would be a whole talk in itself, but essentially a little tear inside the artery. Sometimes the tear can be so small that you can't even see it when you put the dye in. If you put the camera down, sometimes you can see it, and we're picking up on more and more of that. And that's very important to pick up on because there can be a recurrent tear in the artery at a different date, and you want to prevent that. Embolism or clot down the artery from another cause, not from plaque. Spasm of the artery, where the artery starts off normal, clamps down and lets up. Microvascular dysfunction, small blood vessel disease. So it's not the large blood vessels that gives you the problem, it's the small blood vessels. And then there are some mimickers of heart attack that are very important. Takotsubo cardiomyopathy, which is a stress-induced cardiomyopathy, very prominent stressor, can actually result in heart function being stunned. Myocarditis, so a viral infection of the heart, or just some sort of supply-demand mismatch or stressor on the heart that causes a heart attack. Suffice it to say, a lot of these causes, particularly Takotsubo, spontaneous coronary artery dissection, small vessel disease, and vasospasm, are much more common in women. And so you can tell if you're just doing the dye test looking for blockages, you can miss all of these different causes. Next slide. And a lot of my colleagues will ask me, why does it matter at the end of the day? Well, it matters because number one, you want to prevent this from happening again. And number two, the therapy for it vastly differs depending upon what cause of a heart attack you found. So if you found a plaque with the camera test, then you would treat them just as if they had plaque that required a stent or bypass surgery. If you had spasm of the artery, you're going to treat them with dilators inside the blood vessels. If they have small vessel disease, there's a whole gamut of therapy you can use. If you have a clot down the artery, you might treat with blood thinners. That dissection, you might treat with beta blockers and aspirin, which will prevent a further event. So it really does matter, and our research shows that when you get them on the right therapy, they do better. Next slide. So this is just to show you that for one of these conditions, which is small vessel disease, all of the different therapies that you can deploy or use in an individual with microvascular dysfunction. Some of it's lifestyle, some of it is preventing plaque buildup, some of it is novel therapy, some of it is chest pain medication, some of it is alternative strategies, even looking at pain control and mental health and cognitive behavioral therapy and optimizing risk factors. And you can see that with all of these, you really ideally should have a multidisciplinary clinic, which is what we've created here in Vancouver. And there's other sites across Canada that have a women's heart health center that allows for multidisciplinary care, where there's often a healthy heart clinic with exercise and diet, nurse practitioners, follow-up. All of the different tests are used, so that can be quite helpful. Next slide. And just to finish my part off about this, just to go through the women's heart disease symptoms. So first of all, I want to start off with a quote. This is Carolyn Thomas. She's a heart attack survivor. She actually has a blog, and she's written a number of books, and she's just really amazing. And she said, in my mind, the stereotypical heart attack was an old guy clutching his chest on a golf course. Women need to know that they can have a heart attack, yet they can walk, talk, work. And that was her experience. She didn't know that she was having a heart attack initially because she didn't have those classic symptoms. So just keeping in mind in women that still chest discomfort is the #1 symptom, but they can describe it differently. They can describe it as tightness instead of the elephant on the chest. They can have other symptoms like sweating and shortness of breath and nausea and lightheadedness. They can have jaw pain. Some of my patients just say, I've been to the dentist 5 times. They tell me my teeth are fine, and yet I have this jaw pain, and it turns out to all be heart related. So keep all of those in mind. I'll turn it over to Emily now to discuss about some of our research and some of our research behind risk factors.
Thank you, Dr. Sedlak, and thank you, Tamil, and everyone for the invitation to present today. So I'll be briefly going over the research as Dr. Sedlak mentioned. So I'm going to start an overview of what we understand about risk factors for heart disease. You can see here in 3 group categories. We have risk factors that are shared between both men and women. We have some cardiac risk factors that are more impactful in women, and then women-specific risk factors. So I'll break that down. So in blue, we have high cholesterol, high blood pressure, smoking, diabetes, abdominal obesity, psychosocial factors like depression, anxiety, excess alcohol consumption, lack of physical activity, and decreased fruit and vegetable intake. So these risk factors are quote unquote traditional risk factors that most people often think of when they think about moderating heart disease. But importantly, emerging research in the last decade or so has shown that some risk factors have stronger risk effects in women compared to men. And specifically, smoking, diabetes, and psychosocial factors like depression and anxiety have shown up consistently across studies, across race, ethnicity, diversity of groups. To have higher risk effect sizes in women. So what that means is, for example, a woman with diabetes is at a higher relative risk of developing heart disease compared to a man of equivalent age and other risk factor status. Importantly, women-specific cardiac risk factors are understudied partly because they are under-collected in research study designs and underreported or undercollected in the clinical settings when the provider is collecting this information. That is often the source for research data. So we really need to encourage from the grassroots to really collect this information so we understand more. So hormone therapies, like for example, during menopause transitions with estrogen and or progesterone therapies. Menopause, as Dr. Sedlak mentioned, premature, some people use cutoffs of 45 or 40 years old. That's a risk factor if you have it start before then. Breast cancer treatments, could be an entire talk of itself, but basically because the radiation therapy is physically close to the heart, there can be side effects. Polycystic ovarian syndrome, PCOS, without going into detail, this is hypothesized by researchers to be associated with the testosterone ratios that are often seen to be different in women with PCOS compared to those without. Importantly, pregnancy complications. So working with the cardio-obstetrics team and the OB-GYN, family doctor, midwives community to raise awareness that any of these complications can be independent risk factors for heart disease later in life for women. So gestational diabetes, hypertensive disorders of pregnancy, including preeclampsia, gestational hypertension, preterm delivery, placenta abruption, stillbirth, etc. So we conducted a study that was published last year looking at non-traditional risk factors and risk modifiers in women with obstructive coronary artery disease using the SAVE BC study shown here in red, compared to our clinic with Women's Heart Clinic patients with MINOCA or INOCA. Specifically, this was a premature onset cohort analysis, so women under 55 at the age of their first angiogram. And we were interested in looking at the prevalence of non-traditional, quote unquote, risk factors because of their potential shared underlying risk modification. What that means is how migraines, depression, anxiety, preeclampsia, and autoimmune disease, all things that are more common in women than men, might associate with these different categories of heart disease. And what we found were that migraines, depression and anxiety, and preeclampsia specifically were much more significantly prevalent in our non-obstructive cohort, the Women's Heart Clinic, compared to the SAVE-BC, the obstructive CAT cohort. Importantly, migraines specifically, we saw 46% of our women under 55 who had migraines. The Canadian population is 8%. And the SAVE-BC cohort was 5%. So that's an example of a risk factor that could be collected in future studies and just in the clinic as a potential risk factor for later heart disease in women that might present, quote unquote, non-traditionally, like Dr. Sedlak mentioned, normal angiograms. To the depression anxiety piece, this was also significant in our study as a risk modifier for non-obstructive disease. We know from the stats that over 2 times more women than men suffer from depression and from post-cardiac diagnosis mood disorders. And this statistic is pretty complicated in how it's obtained. I understand it's murky area when you're assessing for depression, but researchers use things like questionnaires that assess different metrics along the mood disorder spectrum. They don't just rely on a clinical diagnosis. And we recognize that there is reporting bias between men and women. However, this statistic is quite replicated across studies globally, worldwide, across different cultures and age groups. So it's pretty robust. And importantly, lifetime risk, but also more specifically within the more recent history, acute depression and anxiety can increase a woman's risk for a cardiac event by 50 to 70%. And as Dr. Sedlak mentioned earlier, there's the stress Takotsubo syndrome as one of those non-ischemic mimickers. Broken heart syndrome can be caused by a very stressful event, can be kind of the trigger. And 90% of the cases of stress-induced cardiomyopathy are actually seen in women. So there's a lot of ongoing research trying to understand, like, why are women disproportionately affected by this transient cardiomyopathy? Shifting gears a bit, I'm going to describe some key findings from a study that we recently published in CJC Open, looking at longitudinal data followed for over 3 years of women who attended our clinic here in Vancouver, BC, who had either Minoka or Inoka. So the first key finding was that we saw a drastic improvement in diagnostic rates. 80% of the women who came to our clinic at baseline did not have a specific understanding of the etiology, like the underlying reason for their heart attack with no obstructive coronaries or just their chest pain with no obstructive coronaries. Because we have a dedicated SCAD clinic at VGH, most of the patients funneled to Dr. Sedlak and the nurse practitioner team here are not SCAD. So that's a bit underrepresented in our study. We saw predominantly coronary microvascular dysfunction, CMD over half, followed by vasospasm. And we found these findings were probably so drastic because we have access to the specialized testing modalities and the specialists to interpret the results that likely contribute to this diagnostic clarity. For example, with the angiogram, you can do a special test called coronary reactivity testing to quantitatively determine that the patient has CMD or vasospasm, as opposed to just assessing through clinical symptoms. A key finding, this is a bit of a dense slide, but the key findings is that before attending the clinic, the patients had medications in red. And then following 3 years, different therapies were trialed. And by the time they were at year 3, they were mostly stable. Like most of them found the medications that were working for them. And those changes are reflected in the blue bars. So you can see some drastic changes in the before and after. Importantly, some differences exist partly because MIs, like Minokas, the people are usually hospitalized. So post-heart attack management is usually more standardized compared to chest pain management, Inoka. The most commonly prescribed in Minoka were short-acting and long-acting nitrates. And the most commonly deprescribed medications included non-acetylsalicylic acid antiplatelets. So basically antiplatelets that aren't aspirin were the most commonly deprescribed. And for Inoka, panel B, it's less standardized, we think, partly due to management of specialists and non-specialists of angina, like it's of chest pain. People have different approaches depending on their training and familiarity, and also the symptoms in the person in front of them. The most commonly prescribed medications include nitrates, calcium channel blockers, and ranolazine. And the most commonly deprescribed medications included aspirin and beta blockers for the Inoka population. We're almost done, 2 more slides. So more improvements in Inoka than Minoka overall seen in our clinic. We assessed this using a clinically relevant metric. And we saw that the Inoka patients fared a bit better after 3 years compared to Minoka. And we think this is partly because there's more heterogeneity in the Minoka etiologies, and there's more unpredictable chest pain patterns in Minoka. Specifically, there's more chest pain at rest and chest pain when sleeping, so they're a bit more unpredictable. So we hypothesized that might have to do with differences in self-reported chest pain and quality of life later. Lastly, an important takeaway is that we did find that after attendance at the Women's Heart Clinic, there were a significant decrease in the numbers of emergency room visits and hospitalizations for cardiac reasons, from 63% to 39% respectively for ER and 15% to 6% for hospitalizations. All right, so back to Dr. Sedlak.
Yeah, so just in the last minute, so why do we need research and funding for women's heart health? We're underrepresented in research. Women are not just small men. As you can see from our talk today, there's different entities and causes for heart attacks and heart disease in women, and so you need this specialized testing. And there's pregnancy, hormones, and menopause, which obviously can't be studied in men and should be studied more in women. Next slide. How can we protect our heart? Regular exercise, healthy diet, stress control and mental health, avoidance of smoking, and get regular checkups. As I said at the beginning, just book an appointment with your family doctor to talk only about heart health and your risk factors. Next slide. So this is the final slide, just showing the future. What do we need to do? We need to build awareness, just as we're doing today, invest in women, empower women, emphasize more research in women, and create dedicated women's heart health centers where we can do all of these things in a multidisciplinary approach. Next slide. And with that, I just want to thank you and thank the WHRI Catalyst Grant, who've been supporting us, VGH Research Group, and of course, Leslie Diamond.
Thanks very much, Tara and Emily. And to everyone who is putting questions in the chat, as I noted at the outset, we are going to come back to these. And I suspect that, in fact, some of the questions that have been raised might be answered now. So I'm going to turn now to Dr. Sophia Ahmed, who is going to speak about menopause and cardiovascular health. Sophia is a professor in the Faculty of Medicine and Dentistry at the University of Alberta. She's a clinician scientist with a focus on sex and gender differences in kidney and cardiovascular outcomes, and is the University of Alberta Chair in Sex and Gender. She is also the chair of the Canadian Institutes of Health Research Institute of Gender and Health Advisory Board, chair of the Canadian Medical Association Journal Governing Council, and president of the Organization for the Study of Sex Differences. Welcome, Sophia.
Thank you very much for that kind introduction. And I'm truly honored to be part of this incredible group of panelists today. And I've already seen a lot of the questions in the audience, and they are fantastic as well. So I'm here in the next 20 minutes or so to talk about menopause and cardiovascular health. And as we mentioned, I do have speaker disclosures, none of which pay any money, as probably no one in this audience or panel is surprised. There's not a lot of money in sex and gender or women's health. But it is important to recognize that these positions do influence the work I do and how I see the world. So over the next 20 minutes or so, we'll be talking about what is menopause and cardiovascular health, and a bit of a roadmap going forward. And I'll make a real effort to not replicate what my incredible colleagues have just outlined in their presentations. And there we go. So just to talk a little bit about menopause, which, it is something that has happened for millennia, as everyone here knows, and there's still a lot of mystery, I'll use that word, around it. So this is North American data from the North American Menopause Society, but so it definitely includes American, but does include Canadian data as well. So the average age of menopause defined by when someone's period stopped is age 51 in North America, and 51.4 if you want to be really exact. And what that means, and looking down here, that just means, and this is a universally accepted definition, 12 months have passed without a period. So someone has started having a period at some point in their lives, and 12 months have stopped. And if you have not had a period for 12 months, congratulations, you are now menopausal, and you're part of the club. And it's a big club. So currently in the US, it's estimated that there's about 50 million people who are menopausal. And I actually want to preface it. I want to make sure I'm using person first in an inclusive language. And I am, to not make any assumptions, I'm going to use the language of the studies that I am citing, which is usually binary, which is usually cisnormative. And so but I just want to tell you that's why I'm talking this way. So anyway, so currently in the US, there are 50 million people who are presumably menopausal. And the WHO says by this year, 2025, there's 1 billion people on the planet who are menopausal. So as I said, if you're one of those people, welcome to the club. There's about 5% of people who develop what is termed early menopause or primary ovarian insufficiency, or I mean, there's lots of different words for it. Before the age of 51, so basically it means they become menopausal, and it's unrelated to a health condition. So certainly, as Emily was saying, there's lots of reasons why people can have earlier menopause, but sometimes it just happens, and that is a not insignificant percentage of people. And it's also important to recognize that symptoms associated with menopause, we talk about insomnia, hot flashes, vaginal dryness, etc., they can all start 8 years prior to menopause, and probably longer in some people. So there's a lot of, and I use the word mystery, there shouldn't be, but just so we're talking about the same thing. And it's really important. Sorry, I keep pressing the wrong button. So because there's not a lot of standardization about menopause. So this is adapted. So this is what the WHO in 1996 talked about, or used as their figure to talk about what menopause is. And so here we are, the final menstrual period here. They talked about it was kind of variable, the menopausal transition. There was perimenopause. After a year without periods, you became postmenopausal. And I cannot believe they used to use the words until demise, but they did. So I'm really pleased to say that there is a more nuanced understanding of what menopause is. And so this is, and certainly this has been updated since then. This is 2012, but just to highlight, there are so many more classifications and understanding that menopause is not this catch-all phrase. There's so many different phases and stages of menopause, but we still have that final menstrual period. And that means that 12 months after that, that's when you are menopausal. But we are still not very good as a scientific community and as a medical and a health professional community at talking about menopause. So when we look at, this is a beautiful review of menopause nomenclature, when we talk about collection of data, and Emily outlined that beautifully in her presentation. We just say, are you menopausal? We don't ask about what type of hormone therapy. We don't ask what type of menopause people have had. We say they're premenopausal. Well, what does that mean? How did we define it? They're postmenopausal. What does that mean? And we can definitely do better as a community. So around the time of the last menstrual period, so there's an increase in FSH levels and there's a decrease in estradiol levels. And I'm going to focus on cardiovascular health concerns do occur around the time of this final menstrual period and around the time of this drop in serum estradiol. But there is surprisingly, there's a systematic review that looked at levels of estradiol levels, serum estradiol and cardiovascular outcomes. And there's surprisingly not a lot of great studies that have specifically linked low estradiol to cardiovascular risk. That doesn't mean it doesn't exist, but just to highlight that there's a paucity of research around this area, which Dr. Sedlak, and I'm going to keep saying the message, this is an underfunded area, and Lisa said it too, that we don't actually know why specifically there is this sudden increase in cardiovascular risk around the age of menopause. And there is a not insignificant part of our scientific community who thinks it's just age-related and actually has nothing, menopause just happens to be something that happens around the age of 50. But moving on here. And as was outlined in the questions earlier, so there's a lot more that goes to menopause that links it to cardiovascular risk. So certainly there's menopause, but there's timing of menopause. What age someone develops menopause or has their last menstrual period. And this is an epidemiological study. It's 20 odd years old, but it's been replicated. And we know this, that people who have early menopause, so i.e., well, there's a dose relationship, if you will. The later or the older one is when they have menopause, it's associated, and I really want to stress these are associations. This is not a cause and effect, an increase in life expectancy. So people under the age of 40, when they develop menopause, have shorter life expectancy than people who are over the age of 55. That isn't to say that they all develop the same life path in terms of development of chronic illness, etc. People in the earlier ages tend to have more cardiovascular disease, and people who have menopause in the later ages actually develop more breast cancer. So it's a bit of, I'll use the word trade-off, but again, an area under active research. So there's a systematic review that came out looking at specifically this age of onset of menopause. So how old was a person when they developed or became menopausal, and when they or if they developed important cardiovascular events, including death, including hospitalization, including having a heart attack or myocardial infarction. And so basically what they found is that, yes, they compared people who were under the age of 45 when they developed menopause. They did not ask or record why they developed menopause at the age of 45. And, I'm thinking of Dr. Sedlak's story of when she was a resident and a person who had recently had an oophorectomy. So there are people who have surgical menopause. There are also people who just develop menopause through age alone. There are also people who develop menopause because they're exposed to, for example, a chemotherapeutic agent. All of these things can influence one's risk. And we don't collect that data, as Emily said. So at least in this systematic review, what they did is specifically look at the age of menopause. Were you under the age of 45 when the person developed menopause, or this compared to 51, the average age of menopause, or later? And they found that for basically any type of cardiovascular event, those people who had menopause before the age of 45 were more likely to have higher coronary heart disease risk. They were more likely to have a risk of stroke. I don't know how well you can see this, but all-cause mortality, cardiovascular disease mortality. So basically, early menopause is associated, well, before the age of 45, associated with cardiovascular risk. And if you look at the guidelines, international guidelines for hormone therapy, people who do develop menopause earlier on it's recommended that they are offered menopausal hormone therapy. And I really want to stress it's a very individual reason why people would be offered, because there are reasons why it wouldn't be a good idea, but that they could take it until the average age of menopause, which is 51, and then between the person and their healthcare provider can decide if continuing hormone therapy is right for them. So we've talked a little bit, well, more than a little bit, about menopause, but there is a recognition that, maybe we shouldn't just focus on this one time in a person's life, but maybe it's the lifetime exposure to what I'll say is, we think, estradiol, which of course goes up and down through the reproductive life years. And maybe we should start asking people when they first had their period. And you will hear pushback on that from some researchers that, no one's going to remember when they first had their period. Like, everybody remembers where they were, what they were doing when they first had their period. And I know people in the audience that are nodding away with me right now. So there's this concept called reproductive lifespan, where it's just the age of menopause and you subtract the age of menarche. And generally what's considered, I'm going to use the word normal, maybe typical is a better word, because really, as you can imagine, there's huge variation, but is kind of between the ages of years 36 to 38, sort of close to 40 is the average or typical reproductive lifespan. So what this group did is they looked at the association between reproductive lifespan and risk of having a non-fatal cardiac event. And basically, as I said, so they decided to use as their referent group people who had a reproductive lifespan between the years of 36 and 38. And when people had their first period, so menarche, and they decided that menarche was age 13. Now, this is really important, right? Because we know that worldwide, girls are having their periods earlier and earlier. So, but anyway, they decided to choose 13. And they found that compared to individuals who had a reproductive lifespan that was under 33 years and who had started their periods before the age of 11, there was a doubling in terms of risk of having a cardiac event. So just highlighting that, yes, I know we're talking about menopause today, but perhaps we really should be talking about reproductive lifespan. Now, I had touched briefly on postmenopausal or menopausal hormone therapy, also commonly used hormone replacement therapy. And you'll still see that it's not an inappropriate term, but the word replacement does imply deficiency. And this is a normal, I really want to emphasize that menopause it's a sign of successful aging. It means one has lived long enough to become menopausal. So it's really not replacement. But anyway, so we talk about menopausal hormone therapy. and, whether we should take it or not. And that's a much larger conversation for probably another day. But it's important to recognize that when we talk about menopausal hormone therapy, it's like talking about antibiotics. So there are like a million different types of antibiotics. They have different doses, they have different types, they have different indications, different effects. And it's no different from menopausal hormone therapy. So, factors that are really important to take into account, this is both clinically, but definitely in research, if we're supposed to get answers, is at what age does one take their menopause? How long do their menopause, their hormone therapy, how long do they take it? What dose do they take? What type of estrogen do they take? There's so many different types. What do they take a progestin with it or not? And there's so many different types of progestin. I forgot to write route of administration as well. Is it taken by mouth? Is it taken through a patch? Is it a vaginal dose? And then certainly timing since menopause. If at least observational data suggests that if one is taking hormone therapy closer to when one became menopausal, i.e. within 10 years, that's probably, I want to be really careful what I say, but more associated with cardiovascular protection than if one takes it, 20 years after that last menstrual period. So just to finish up, just to highlight, and so if this paper is from 2003, but it's a really nice review about why there are so many, there seem so many papers out there, like some that suggest taking hormone therapy is cardioprotective. There are some that suggest, and one big one in particular that suggests that it's not good for you. And it's really because of a lack of incorporation of all those different factors that I showed you on the different slide to understand the nuances of how menopausal hormone therapy can affect cardiovascular health. So just to, in the last few minutes, so Dr. Cindy Kalenga was a PhD student in our lab. She's now at UBC. She's a first-year internal medicine resident. And as part of her PhD, she did an administrative data study in Alberta looking at specifically trying to get at these specific factors about hormone therapy and how do they affect cardiovascular risk. So she specifically looked at hypertension. So what she did, it was just over 100,000 people. These are all people over the age of 45. So remember trying to get away from that. We know that having early menopause is associated with cardiovascular risk. So let's look at people who are older than that. And she looked at people who were only taking estrogen. So let's get rid of that progestin complicating factor. And she looked at age at which we didn't know what menopausal age, but we knew the age of the participants. We knew what type of estrogen they were taking. We knew the route of administration, and we knew how long they were taking it for. And the bottom line is we found that oral estrogen, people who are taking oral estrogen had a higher risk of developing hypertension compared to people who were taking transdermal or people who were taking transvaginal estrogen. And we also found that people who were taking conjugated equine estrogen, which was the type of estrogen that was used in that big randomized controlled trial, the Women's Health Initiative, that suggested there was a problem with hormone therapy and cardiovascular health, those people had higher risk of developing hypertension compared to people who took estradiol, which is more similar to what the ovaries make. And so the bottom line from the study was that so people need to take hormone therapy for really good reasons. People have terrible symptoms from menopause. They can lose their jobs. They can have, really, it can have a really negative impact on their relationships. So it is very important and individualized why people take hormone therapy. And if someone is going to take hormone therapy, at least from a cardiovascular perspective, from a hypertension risk perspective, taking estradiol for the lowest dose for the lowest amount of time is appropriate. But I really want to stress that needs to be balanced with those other reasons why someone's taking hormone therapy in the first place. And I just want to highlight why, and really call out and Cindy for the great work that she did. This is a systematic review that came out shortly after her paper, looking at the effect of hormone therapy on blood pressure and hypertension in postmenopausal women. And while there are suggestions that maybe taking hormone therapy not by mouth, but by patch or other is better for hypertension risk, all of the studies suffered from those problems that we just discussed. So lack of, how is menopause defined? What type of hormone therapy were people taking? How long they were taking, the age. So just a real call out again to emphasize what my colleagues on this call have already emphasized. We really need to be better as a scientific community and clinical community, because as Emily said, that's where we get some of our scientific data in collecting this, collecting these important factors that we know are associated with risk. So do we know that reproductive lifespan, menopause, menopausal hormone therapy influence cardiovascular risk and death? No, we do not. The jury is still out. But as Lisa said, there is a change. And this is the headline from Newsweek. This is 2016, so it's like super old now. But like, I'm going to say it, like, there will be blood. Like, we all have to get over. It's really important. And I'm so pleased. And thank you, Tamil, for organizing this, that we're talking about menopause and menstrual cycles and periods and contraception and menopausal hormone therapy, and normalizing and destigmatizing the conversations around it, both here and in the clinic and in research, because we know this is important to women's cardiovascular health, and we need to get past it. So with that, I thank my funders and certainly my lab, without whom I couldn't do any of this, and my partner in crime here, Dr. Sandy Demansky. And I'll end there. So thanks very much.
Thanks so much, Sophia. Fascinating talk. And again, I want to really underline what I'm hearing here about the importance of improving that data that we collect in the clinical encounters, so that we start to really understand more about women's health and the intersections with menstrual health and the lifespan and cardiovascular risk. Now I'm going to invite Carrie-Ann Mullen and Jennifer Monahan to talk about maximizing research impact and improving cardiovascular health for women in Canada through meaningful partnerships and knowledge mobilization. Dr. Mullen is a scientist and the director of the Canadian Women's Heart Health Centre at the University of Ottawa Heart Institute. She's also an assistant professor in the School of Epidemiology and Public Health at the University of Ottawa and current chair of the Canadian Women's Heart Health Alliance. She recently received a Knowledge Mobilization Excellence Award and an Equity, Diversity, and Inclusion Award in research in recognition of her partnership and approaches to research with people with lived experience and underserved populations. She's joined to give this talk by Jennifer Monahan, who was only 43 when, without any risk factors or symptoms, her stroke and discovery of cardiomyopathy happened. After relearning her ABCs and 1, 2, 3s, as well as regaining use of her right side, she turned to volunteering and found a meaningful path forward. A lawyer by training, she is engaged in many national, provincial, and local health initiatives and is a member of the executive committee of both the Stroke COG Recovery Trials and the Canadian Women's Heart Health Alliance. So I really want to warmly welcome both Carrie-Ann and Jennifer, and also invite the panelists. If there are questions that you want to respond to in the chat, please go ahead. Carrie-Ann and Jennifer, I'll turn it over to you.
Thanks very much. Thanks for this kind invitation, and to all of the presenters. What a wonderful panel. Thank you for your presentations and highlighting the research that you are doing, really important research in Canada to improve heart and vascular health. And we're going to talk to you a little bit more about research and how we're trying to maximize research through meaningful partnerships and knowledge mobilization in Canada, building on a lot of what Lisa talked about, the work of the Canadian Women's Heart Health Alliance. It's my pleasure to be joined by Jennifer Monahan, who you'll hear from in a moment, my co-chair in the research and knowledge generation arm of our alliance. Here are just some learning objectives for the next 20 minutes of our talk. Talk about some gaps in research, how we're trying to maximize research input, identifying opportunities for promoting gender equity in research for women in Canada, and really highlighting meaningful partnerships with persons with lived experience to improve our research overall and improve health outcomes. So with that, I'll pass it over to Jennifer.
Thank you, Carrie. The Women's Heart Health Alliance is an incredible organization. As a person with lived experience, I want to point out the fact that they are including and engaging with patient partners like myself on each and every pillar of the Alliance. There is a co-chair who is a professional like Carrie, and also a co-chair who is a patient like myself. And that's been the way they've been doing it since the beginning, and they're very advanced in their engagement with patient partners. And the second thing I want to point out on this chart is the incredible growth that we have enjoyed. When we started in 2018, there was only 55 members, and today we're up to 250. And those are a mix of all of different positions and careers that people are coming from, and they're also a great mix of diversity. So those are some of the highlights I want to bring up, and Lisa had spoken about this in her presentation. So I will move on to my story. I had a stroke almost 13 years ago. That's a picture of my family 1 month before the stroke, and then the second picture 11 and a half years later. I think the biggest difference is in the height of my son, who is a lot taller than me now. When I had a stroke, I didn't even know what a stroke was. I didn't know what was happening to me, and I definitely didn't know anyone who had ever had one. Nevertheless, I suffered a devastating stroke, and the only option available to me, and it was the best treatment available, was a clot-busting drugs called TPA. Research has since improved treatment options, and now doctors can go right into the brain and pull out clots quicker and safer than my treatment. So I'll begin by saying thank goodness for research. While in the hospital, I had a lot of tests run on me to try and figure out why I had a stroke, because I had no traditional risk factors at all. The doctors discovered I had cardiomyopathy, which is a heart muscle disease. For my stroke, I had no symptoms of any heart condition, and for about 6 years after, I still had no symptoms. So I knew it was there in the back of my mind, and I saw my cardiologist regularly, but it didn't really mean much to me until I started having difficulty walking upstairs, or walking up a slight increase in the road. And my cardiology has since progressed into heart failure, for which I take all medications that are prescribed to me, and recently had my very own defibrillator installed. Now, I was a lawyer before I had a stroke and had no interest ever in science or math. My health changed my life in a lot of ways, but it also gave me a far more meaningful and fulfilling path or career of volunteering. I have, for the past few years in that volunteering, become passionate about research. And I both advocate for engagement of patient partners in research, And I myself engage in many research projects. This year, even for the first time, I am co-leading a research project on the brain implications of heart failure. Next slide, please. And as a patient partner, I want to return to this slide because it's hard to accept that 2/3 of heart disease research has focused on men. That means that despite the fact that women make up over half the population, they haven't been studied. And as a result, all the strategies used to identify, treat, support, research heart disease have been based on data that was primarily middle-aged white men research subjects. And that makes me question the treatment I am getting as a woman. And Lisa went over the reasons why this is important for us today. Next slide, please.
So in knowing this and knowing the gaps in research, one of the first research outputs of the Canadian Women's Heart Health Alliance was to publish an atlas, a 9-chapter atlas, which is really a contemporary review of pretty much everything there is to know in terms of the epidemiology, diagnosis, and management of heart and vascular disease in women. This atlas is fully published now in the Canadian Journal of Cardiology Open, and you can see the different topics of the chapters listed here. Importantly, authors of this atlas or this contemporary review were just as diverse as the Alliance members are. It included researchers, clinicians, women with lived experience, and trainees all working together to complete these reviews. Chapter 3 is unique specifically as it was led by patient partners and really focuses on the patient perspective when it comes to being diagnosed and the management of cardiovascular disease. Just last year, Chapter 9 was published, and it focused on specific recommendations, challenges, and opportunities, which I'll go over in a moment. But this atlas is really meant to be a living document on the current state of heart disease in women across Canada. What it has led to is really a foundation for knowledge and leadership in this area for those of us who've been involved in the creation of the atlas. As I mentioned, it's interdisciplinary and had a very strong person with lived experience collaboration, which is unique for this type of academic research. It's led to some national and global opportunities, but also has led to sort of future research ideas in terms of identifying those gaps, which ideally will result in impactful change. I mentioned Chapter 9, which was our final, which sort of summed up the entire atlas, but it had recommendations at the clinical level, the advocacy level, but also at the research level. And really acts as a call to action for researchers, the public, and policymakers around sex and gender in terms of cardiovascular research. So specifically, there are recommendations around targeted education and support, recommending that there is sex and gender training, both in terms of the concepts, but also methodology in research. There is recommendations around building a culture of inclusivity and diversity, ensuring that there's equitable representation of women, ethnic, and racial minorities, and that also this is included in terms of clinical trial leadership, that we see diverse groups of individuals leading this research. There's recommendations for advocating for change, really help trying to understand hesitancy to participate in research, and looking for mitigation strategies so we can include, or we can ensure that we are able to include more women in the research that we're doing. And this includes having patient partners in research, like Jennifer is, like many other people on the Alliance are, and Jennifer is going to speak more to patient partnership later on in the presentation. And then finally, there's recommendations for funding agencies, scientific journals, and conferences to ensure that we continue to enforce sex and gender reporting in our guidelines, and also require this for funding publication and scientific conferences. Moving along to 2 years ago, the Alliance was successful in receiving funding from the Canadian Institutes of Health Research as one of 10 women's health hubs. So are specifically focusing on heart and vascular health in women. And here are the main objectives of this funding opportunity, which we're almost halfway through and are implementing some important research strategies. Number one was to focus on implementing new and scaling existing evidence-based strategies around improving awareness, prevention, detection, and management of cardiovascular disease in women. So essentially, taking what we know, taking successful, effective interventions and programs, and trying to translate that knowledge and implement them to a greater scale. Number two was maximizing our research impact. And specifically, this was actually developing a new research arm of the Alliance, which Jennifer and I co-chair. Prior to this, we have certainly had research outputs, but our focus was mainly on knowledge mobilization and advocacy education. And now we have a specific research arm that's helping to generate new knowledge. Third, focus is building capacity for the next generation of health researchers by enhancing education, training, and mentorship opportunities. So this is really all about teaching our leaders, our research and clinical leaders of the future, about the importance of sex and gender, about the importance of research in women's cardiovascular health, and creating opportunities for these trainees to learn from others working in this area. And then finally, an important objective is to engage underserved populations to help us identify gaps and opportunities for future research and innovative interventions in women's cardiovascular health. So just quickly, some work that's underway from our group, being led by various members of our Alliance and co-investigators of this hub. One is a publication guideline, as we do publish. Atlas is one example. We've published dozens of other publications with the Alliance, again, using an interdisciplinary, multidisciplinary team. So it's really shoring up our guidelines on publication engagement, authorship, and so on with such interdisciplinary teams. The second is looking at trends and sex differences in cardiovascular disease over the last decade. And this is with high data and something we're working on currently. Third is an online patient-informed registry and research platform. The beginnings of this are already available on the Alliance website, cwhha.ca. And currently, what the initial stages of this allow researchers to publish their research or promote their research for which they are actively recruiting, and individuals can scan this and reach out to researchers if they're interested in participating. And it's also an opportunity for persons with lived experience to become engaged as research partners. The Learn project is part of that mentorship around trainees and early career researchers. So we are launching this year a research trainee and early career research mentoring program, allowing trainees to be matched with more senior investigators, but also interact with patient partners in research to learn key principles as they build their own careers. The fourth objective of the hub was to reach underserved populations under the leadership of Monica Perry out of the University of Toronto. We received a Catalyst grant from CIHR called Crowning Us, and this project is all about cardiovascular risk across the lifespan with women, intersex, gender diverse, and underserved people in Canada. Our main objectives are to engage underserved populations, but also working with those communities and individuals is to identify research priorities around women's heart and vascular health with these groups. And then finally, we have established and launched several award opportunities for both trainees, early career investigators, and also people with lived experience, including travel awards that allow, give funding, for example, for some of our patient partners to attend our academic conferences and other events around women's heart and vascular health research.
Thank you. And as Carrie was talking about the Crowning Us research and reaching a diversity of women, women aren't obviously meeting half or 50% of subjects in research to begin with, and then in the lower percent, they're not reaching diverse women, people with Indigenous heritage, ethnic and racial minorities. And so by prioritizing women's heart health in research, we will hopefully have that number change, because 26.5% of Canada's population are racial minorities, and they have a higher risk profile in heart disease. Next slide. This is just a quick slide to ensure everyone uses the correct language and the differences between the subjects who may be participating in your research and, for instance, getting the treatment being studied, and those that are engaging in your on your research team as patient partners. Next slide, please. And patient partners is a term used to indicate, all people who've had experience with a health issue, their caregivers, family, and friends. And they are experts. They are experts in all of the things here, the symptoms, diagnosis, treatment. They have lived all of this. And the professionals here may not have, and probably have not, lived through that. So, but they are experts on the various aspects of the conditions we have. They are educated, they work in the field, but they rarely have lived experience in it. And patients' perspectives are different than such professionals. Now, not all women with lived experience in heart disease know that their heart health experiences qualify them as an expert member of a research team. But nor do all researchers know how to, that patient partners should be involved in research and are increasingly required to be on a research team by funders. The researchers here may not know how or why to engage patient partners. Next slide. So this is a quick slide about why you should engage patient partners from these three perspectives. From the person with lived experience, the reason why we want to participate in research teams is to ensure that the research is relevant to our needs, whereas a funder might want to be able to demonstrate that the heart research this way, they can rely on the engagement and build collaborative solutions that are best possible to deliver equitable healthcare. And scientists yourselves, it's a chance for you to improve not only how your research is done, but the outcomes of your research. Next slide, please. And this slide is how to engage. Unfortunately, the slide is too small for me to print the entire planning document that is on the right-hand side, but that comes from the Newfoundland SPORE support unit, and the site is there. But this is a great site for you to go to, and it helps you think about what you should do to get organized to engage patients, where you can find them, how you should approach them, where they can help with your research, and how important issues such as compensation and recognition. And I also want to say that engaging patient partners on research team is a culture change, and it's new to a lot of researchers. And because of that, there are some barriers to good patient engagement. And those include, for instance, power imbalances, because of the status perceived between a patient and a doctor of something. It's best for you to use first names in meetings, so you are leveling that power imbalances. And the power imbalances are beyond titles. It may be the economic situation, and it may be divergent cultural protocols. But you can overcome all of these if you build relationships with your patient partners. You have to remember that they are people first, patients second, and you should get to know who they are, their skills and interests, and you should share some of your own life with them as well. And approach them as you would any other member of your research team. Get to know them, bring them into meetings, and introduce them, and check back with them frequently to ensure that they are comfortable with what's going on, and they may need a quick overview of the lingo and the abbreviations you use in your work, so that they don't get lost. You should also try to avoid acronyms if you can, and be respectful of their time and their resources. Thank you.
So thanks very much. We'd just like to acknowledge the Alliance, our secretariat, our members, all those who've contributed to the work that we do and continue to contribute their time and energy and ideas, and especially our persons with lived experience who have made the work truly valuable, and really helped change or create this incredible culture of the Alliance. So thanks very much.
Thank you very much, Jennifer and Carrie Ann. My own background is in, I come from HIV and the HIV movement. So the idea of meaningful engagement of people who are affected is very close to my own heart. So thank you so much for lifting this up in the women's heart health space. Now for our last presentation, I'm delighted to welcome Dr. Nan Chen, who is a postdoctoral fellow with the Partnership for Women's Health Research Canada, who is going to provide us with an overview of national investments in women's cardiovascular health research over the past 24 years. Nan holds a PhD in epidemiology and health statistics from Sichuan University in Chengdu, China, and she has a research background in healthcare resource location and allocation optimization for women's and maternal health. And as I noted, she's a postdoctoral fellow with Power at the University of British Columbia. Thank you, Nan.
Thank you, Tamil. We have heard from experts today about progress as well as critical knowledge gaps for women's cardiovascular health today. To close, I will share analysis of national funding trends for women's cardiovascular research in Canada from 2000 to 2024. So historically, women have been systematically excluded from health research, resulting in critical knowledge gaps and significant health disparities. To address these issues, policy reforms have been introduced, including CIHR's 2010 Sex and Gender-Based Analysis (SGBA) framework. This policy mandates integration of sex and gender consideration into research, policy development, and funding allocation. However, closing these gaps requires more than policy changes. It demands sustained and targeted investment in women's health research to drive meaningful progress. A key challenge is the lack of economic evidence. Policymakers, research funders, and healthcare leaders consider economic evidence when making funding decisions. This study is to quantify the economic and societal return of investment from increased funding in women's cardiovascular disease research in Canada, providing evidence to guide equitable policy and funding decisions. We choose to focus on cardiovascular disease for two reasons. First, CVD is a major health burden for women. Second, research shows that CVD manifests differently in women than in men, and these differences provide important reference points for parameter settings in our next modeling phase. The first step of our study is to examine investment trends in CVD and women's CVD. For this study, I used the CIHR Grants and Awards database to analyze national investment in cardiovascular research. This database includes two main types of funding: grants and awards. Grants support the direct costs of research projects, including researcher training and activities that facilitate the translation of research findings. CIHR's grants are classified into 7 categories. Awards, on the other hand, mainly provide direct salary support to research personnel or stipend for trainees. It is worth noting that 3 types of grants, team grant, training grant, and chair grant, share similarities with awards. However, since they represent only about 5% of total CVD grants, and CIHR categorizes them as research project funding, I retained them in my analysis, while I exclude award investment. Next, I identified CVD-related projects within the funding data. I used these search terms to identify CVD-related projects based on titles, keywords, and research categories. Similarly, I applied these terms to identify AMI and stroke-related projects within the same search fields. I specifically focused on AMI and stroke because they are among the leading causes of cardiac-related death in women. These conditions will also be key components of the microsimulation model I plan to develop in the next stage of this research. To maintain consistency with ongoing analysis, I conducted this subgroup identification as part of the study framework. Building on this, I also identified projects focused on women and LGBTQ+ research. I used these search terms to identify women-related and LGBTQ+ research projects. This is important because CIHR's SGBA policy, it may have influenced the funding by changing application requirements, review criteria, and increasing awareness. Using this data, I aim to examine whether this policy had an impact and how investment trends changed after 2010. After defining our search criteria, this flowchart illustrates the process of identifying CVD-related funding from the CIHR's grant database. Starting with over 205,000 records, I first removed award program records. Next, I excluded non-CVD related records, leaving nearly 20,000 records. Among these, over 40% are related to AMI or stroke. In terms of CVD and women's CVD investment, the results show that total investment in CVD research has steadily increased over time, peaking at $570 million Canadian dollars in 2021 to 22. The proportion of investment in women-related CVD research saw a noticeable rise following the implementation of SGBA policy in 2010. In the most recent fiscal year, women-related cardiovascular research received $64.8 million, accounting for 13% of total CVD investment. This slide presents trends in AMI research investment with a focus on women-related funding. Total AMI investment has steadily increased over the years, reaching a peak of 152 million Canadian dollars in 2023. The proportion of investment in women-related AMI research rose after the SGBA policy was introduced, but has fluctuated in recent years. In the most recent fiscal year, women-related AMI research received 13.8 million Canadian dollar, representing 9% of total AMI investment. This slide presents stroke research investment trends with a focus on women-related funding. Total stroke investment has steadily grown, peaking at 172 million in 2023 to 24. Similar to AMI, women-related stroke research funding increased after the SGBA policy, but has fluctuated in recent years. In 2023 to 22, it reached 13.8 million, 8% of total stroke investment, slightly lower than the proportion in AMI research. In terms of LGBTQ+ related cardiovascular research funding, overall it remains extremely low, with proportion consistently below 2%. After the SGBA policy in 2010, investments increased slightly, particularly in AMI and stroke research, but funding has remained unstable with no clear upward trend. This slide shows AMI incidence and mortality trends from CCDSS, Canadian Chronic Disease Surveillance System, using age-standardized data. AMI incidence has steadily declined for both the total population and females, reflecting improvements in prevention and early intervention. While total AMI mortality remains stable, female mortality is higher and more variable. Despite lower AMI incidence, females face consistently higher mortality rates, emphasizing the need for more research and targeted investment in female cardiovascular care. Similarly, stroke incidence has steadily declined for both the total population and females, reflecting improvements in prevention and also risk management. Stroke mortality has also decreased over time, with fewer fluctuations than AMI. However, female mortality remains similar to or slightly higher than the total population, highlighting the need for continued research and investment in female-specific stroke care. This analysis of CIHR funding for women's cardiovascular research over the past 2 decades reveals key trends. The SGBA plus policy has increased attention to women's CVD, but historically underfunding and persistent knowledge gaps remain. Female mortality trends highlight the urgency of further investment and better knowledge translation. Funding for two-spirits, LGBTQI+, and other gender diverse individuals remain critically low. These findings reinforce the priority outlined in CIHR's Institute of Gender and Health Research Priority Plan. Before concluding, I'd like to acknowledge the support for this research. This study is funded by MITEX and Power and will be conducted at WHRI UBC. Feel free to reach out if you are interested in discussing this further. My contact information is on the screen. Thank you for your time and attention.
Thank you so much, Nan. And I would like to welcome all of the panelists to join us on screen, and we can address some of the outstanding questions that came through in the chat. And I also encourage folks to put additional questions in the chat. So just noting, there was a question about the specialized women's heart health clinics across Canada, and there are 7 of them, and they are listed on the PWHR website, and the link is in the chat. There was a question raised about the issue of depression and anxiety and women's higher rates of that in links to cardiovascular disease, and a question about, is this related to the medications involved in treating anxiety and depression, or has this not been analyzed? Would someone like to address this question?
Emily may have a research perspective from this. So certainly there is research into some of the antidepressant medication that can prolong an interval on the ACG called the QT interval. And in people who are genetically prone to long QT syndrome, we certainly try to avoid some of these agents because it can increase their risk of having an event. I'm not aware that any of the other antidepressants have a direct cardiovascular link, particularly to our MINOCA and INOCA that we've been studying. Emily, do you have any thoughts on that?
I don't have any thoughts off the top of my head, citations wise, for SSRIs on MINOCA, INOCA. My take on the question is that part of why we see this 2 times higher risk is partly due to the gendered, like the social, non-biological aspects. Like when we look at women, like causes of depression, anxiety in society, increased burdens and like self-perceived stress from social factors, from gendered non-biological factors. Over a long period of time, this can be to power imbalances at the home and workplace, in the cultural context, can reinforce a biological condition called low-grade inflammation. And if this is chronic over time, then that can increase your risk of developing a heart condition, in which, you know, non-therapeutic like interventions like cognitive behavioral therapy and, you know, affecting how, like trying to change how the brain interfaces with the body can be useful, not just medical therapies. And the second research take, that's one research take. The other research take is blood vessels in women are biologically just a bit different than men's in terms of the genetic profile, because we have the capacity to be pregnant. the interface between the brain and the blood vessels around the body are a bit different because the wiring has to adjust for the stress test of pregnancy. So that's another hypothesis that researchers are looking into for how stress manifests in the cardiovascular system from a like biological point of view. So I hope that addresses the question.
Really interesting. And as you raised those gendered issues, I, as moderator, had a question for Jennifer and Carrie Ann, that they raised the issue about, and anyone can answer this, women's under-enrollment or hesitance to be engaged in clinical trials. Could you dig into that a little bit more and help us as researchers to know what we should do in our design, in our recruitment, to make those more welcoming spaces?
I don't know if Jennifer wants to start, or I can suggest a few things. I think there's been some research that has looked into the issue of under enrollment of women and what some of the main barriers are, and many of them won't come as a surprise to those of you on the call, but time is often one of the main barriers to participation for women. A lot of women, especially at the maybe stage of life that they'd be recruited to research, are feeling this sandwich generation. They're often the primary caregivers for parents, for spouses, and for children. And so this becomes a challenging time to be involved in research. So one of the suggestions or the ways to improve participation is trying to reduce the burden and the time commitment for women, trying to reduce the amount of time that individuals may need to go on site to an institution for this research. It's not always possible, and in terms of some of the research that we do, making transportation easy, offering childcare compensation in some cases, or other caregiving compensation. Another reason that a lot of women have not been involved in research has been actually through inclusion exclusion criteria, specifically, excluding certain women. In some research, believe it or not, an exclusion criteria is women of reproductive years, during the reproductive years. I mean, we heard from Dr. Ahmed from Sophia about that reproductive period. That's a massive time period in a woman's life, and actually a really important time in terms of cardiovascular risk, that we actually should be engaging women in research and studying the time period. So there are certainly through inclusion exclusion criteria, we can think of ways of minimizing exclusion of women. Jennifer, any thoughts from your perspective?
Yes, I was just going to add, I'm engaged in a research study that is looking into letting women know about research opportunities, and doing that by a video. So I was engaged to write, to speak in a video about a quick my health history, and why I think being engaged, participating as a subject is worthwhile, and then I introduced the actual research study, and the principal investigator takes over, and it's just a 3 minutes video that we're having presented at the bedside in the hospitals, and hoping that way of publicizing the availability and the opportunity to participate will potentially overcome some of the hesitancies that you were just talking about. Thanks.
Thank you. Carrie Ann, please, you have something to add.
I'll add to that. I think that's really important, Jennifer, and just another way that we're changing things from the research perspective is I think making the research relevant to women is really important. So for our studies where we recruit both men and women, we have started to include in our informed consent forms, specific information to why this question is particularly relevant to women. And I think so, and we've seen greater interest. We were actually struggling to recruit in one study, and we actually changed and included a paragraph in our consent form, and enrollment of women has actually increased since doing that. So I think you're right, Jennifer. It's really making it relevant, trying to make it relevant to women.
Overcoming what you have all talked about, this ongoing stereotype that cardiovascular disease doesn't affect women, that we're still bashing up against this. So, I mean, I thank all of you for your research and your clinical work and your advocacy in this space. I want to go back to a question that came up through the chat around menopause, osteoporosis, and heart health. And this was specifically about the issue of supplemental calcium that can create plaques. And I don't know about this, but the use of vitamin K2 that's also being recommended. Could some of the clinicians weigh in on this issue? Maybe I'll go to you first, Tara, and then see if Sophia has anything that she'd like to add.
Sure. Yeah. So this thought started a number of years ago. In fact, when I was a resident, so that goes back 20 years, I remember a number of papers coming out, bang, 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 suggesting that supplemental calcium could increase the risk of an MI, of a heart attack. And we were all kind of taken aback a bit, just thinking that we could all process calcium normally, and that why would it increase the risk of MI? And over the years, there has been some accrued research. And there was actually a recent, I would say 2021, if I recall correctly, large scale meta-analysis done on this, looking at 12 or 13 different RCTs. And at the end of the day, they did find that supplementing, particularly with elemental calcium, can increase the risk of cardiovascular disease. Now, what I say to people is this is all a risk benefit. It's the same as with hormone replacement therapy, where different people have different risks and different needs. And if their osteoporosis is severe and their heart disease is mild, then maybe the risk outweighs the benefit. The other thing to say is that vitamin D seems to partially mitigate that risk. Dose seems to partially mitigate that risk, so lower dose. And then also taking it in through diet seems to partially mitigate that risk as well.
Great.
I don't know that I have anything to add to that. So, but exactly, if you can get it through diet, get your calcium through diet, that's always preferable. And I certainly am not a dietitian, and really defer to our colleagues' expertise in that area. And one of the thoughts is that when you take a tablet of calcium, you get a sudden bolus and a real sudden rise, acute rise of your serum calcium levels. Whereas if you take it through food, it's more of a gradual absorption. And so you don't get those high ups and downs. And so perhaps that's related to cardiovascular risk. But again, I would defer to our dietary colleagues when it comes, and the same thing with the question about vitamin K. So vitamin K can interfere with some blood thinning medications, and really I wouldn't take anything without discussing it with your healthcare provider. And definitely the dietitians, they really know a lot, and can give a lot of really good advice about how to get these minerals, supplements, etc., just through our food. So I'll leave it there. Thanks.
Great. And I'm going to pick up on one more question from the chat, which is put this way: what about hysterectomy caused by endometriosis being associated with INOCA? And I think that I'll send that back to you, Tara.
Yeah, and we need to look at this more in our data set. Admittedly, we just don't have the numbers yet, and we haven't been properly tracking endometriosis, I think. Emily can correct me if I'm wrong there, but the thought process is that certainly I've written a paper with others on endometriosis alone being a risk factor. Now, whether it's associated with the fact that more people with endometriosis end up on specific treatments or have specific surgeries, such as hysterectomy and oophorectomy, that then put them into premature menopause, and that puts them at risk. Irrespective, there does seem to be a link, and it needs to be better studied in endometriosis just because it's so common. But certainly in this individual, I do think that you know, she was placed into menopause, and then 3 weeks later started to have symptoms. It's quite possible that she had some endothelial dysfunction and some microvascular dysfunction prior to this, but I think the dramatic change in hormones certainly precipitated events, and most likely precipitated her angina and uncovered something that may have been uncovered later in life, but certainly was uncovered at an earlier stage because of those hormonal changes.
One thing I'd like to add is I agree with everything Dr. Sedlak mentioned. We do collect endometriosis on a self-report level, and a lot of the women in our cohort who are in their 50s, 60s, maybe even 70s, often say that they weren't officially diagnosed, but then they go on to explain symptoms, or they explain the heavy periods and like other things that as a non-clinician, I cannot diagnose them with endometriosis. So we record these things as they tell us. If they had a diagnosis, they tell me, I record it. And another thought on this is endometriosis is showing involvement of the immune system, and chronic low-grade inflammation, active immune system does wear and tear on the lining of the blood vessels and downstream processes of heart disease. So that could be another connection.
Thank you very much to all of you, and thanks to everyone who chose to spend these 2 hours this morning and this afternoon here with us. I think that this panel for me has been inspiring again in PWHR's mission to promote and to lift up more research about women, trans, and non-binary people, because we have seen again both the changes that are being made in clinical care through this research and the better outcomes that are possible, but also just how far we are away from meeting our goal of truly equitable and inclusive research that can promote the health of women, trans, and non-binary people. So I thank you all for the fantastic work that you're doing and for taking the time to do these great presentations and to share this knowledge more widely. And I'm really looking forward to wearing red again tomorrow, and to raising awareness of women's heart health across Canada for Wear Red Day. Thanks again, everyone.